My name is Carey Mancuso, and this video covers iron deficiency anemia in women's health. Iron deficiency anemia is a global health concern, and it affects women disproportionately compared to men. We see this problem in all life stages for women, but especially in adolescence, childbearing years, and perimenopause. Women in the United States are impacted more if they're Black or Hispanic compared to Caucasian women. And the impact on quality of life, mental health, work performance, morbidity, and mortality cannot be understated. The most common causes for IDA or iron deficiency anemia in women are heavy menstrual bleeding and pregnancy. Heavy menstrual bleeding goes underreported, so it's difficult to catch these women who are going through this. And pregnancy has this natural increase in iron demand that leads to iron deficiency and anemia for many pregnant women. Other causes, though, can include nutritional deficiencies. We see this in the United States and all over the world in women. Impaired absorption, like malabsorption disorders, IBD, celiac disease, but also proton pump inhibitors or gastric bypass surgery. Iron deficiency without anemia can also be problematic as it can cause significant symptoms. Some women develop fatigue, reduced work or athletic performance, or low quality of life. Early treatment improves symptoms and reduces the risk of anemia, so catch these women early if you can. When we speak about heavy menstrual bleeding, it's difficult to define this. Most women do not measure their blood loss every month. So screening questions that define the blood loss more easily can be very helpful, such as how often are you saturating a pad or tampon? If it's every 1 to 2 hours, even for the first 1 to 2 days, that's too much. Are you bleeding every 7 days? Do you saturate clothing? Is it impacting work or school? All of these questions can lead you to check those iron studies and rule out iron deficiency anemia. In pregnancy, we have this high iron demand state as we discussed, and unfortunately 40% of pregnant women start pregnancy iron deficient, so it should be on your radar pretty early. A ferritin of less than 30 is pretty specific to iron deficiency in pregnancy. Physiologic anemias are expected when women are pregnant because of the increase in plasma volume. Between ACOG and World Health Organization, a hemoglobin of 10.5 to about 11 is normal depending on the trimester. However, iron deficiency can still cause problems for mom and baby. So even women who are meeting the mark of that quote unquote normal hemoglobin should still be screened for iron deficiency. Risks can include low birth weight, small for gestational weight newborns, preterm birth, intrauterine growth restriction, postpartum hemorrhage, infection. We've had associations to an increased risk of schizophrenia for the fetus, autism spectrum disorders, and cognitive and behavioral delays. And some of these risks are related to just low maternal iron. So that ferritin should be checked early in the first trimester and then again in the early third trimester. IV iron can be considered in pregnancy. The World Health Organization recommends starting with 30 to 60 milligrams of iron plus folic acid daily. Some experts are recommending every other day now, and we do that a lot in our practices across the United States for better tolerability and absorption. ACOG states in their 2021 brief that IV iron should be considered in that after the first trimester if oral iron fails or if it's not tolerable. We have a lot of studies out there, including a 2024 Cochrane review that shows IV iron improves outcomes in pregnancy with fewer adverse effects compared to oral iron. And we know that IV iron is more effective than oral iron. So do your research and consider it for your pregnant women if they're not responding to oral iron effectively. Postpartum is another vulnerable time for iron deficiency anemia. The nadir hemoglobin is expected at 48 hours post-birth. And just a reminder that ferritin is unreliable immediately after because it's an acute phase reactant. Iron deficiency anemia has been linked to poor maternal neonatal bonding, so it's an important thing to catch postpartum. And the postpartum depression risk has been higher with iron deficiency anemia, and a study has shown that this risk is reduced with iron therapy. So again, something to be proactive about in your patients. In perimenopause, hormonal shifts cause irregular and heavy bleeding. Symptoms most frequently are fatigue, brain fog, mood changes, sleep disorder, unable to sleep or restless legs. We see depression in 40% of perimenopausal women, and this has been linked to iron deficiency anemia. So we recommend provider vigilance, OB-GYN follow-up, and mental health referrals if needed. In summary, iron deficiency anemia impacts 30 to 40% of women globally, and it's often underrecognized and undertreated. This can lead to reduced quality of life and increase in morbidity and mortality. Iron deficiency without anemia can also impact women and their fetuses, so it's important to catch both. So if your patient is not anemic but has symptoms of iron deficiency, screen for it. We know it's linked to more poor maternal fetal outcomes, and early recognition and treatment are essential and have been shown to improve outcomes in certain populations. Thank you for watching today. I hope you have a great day.